we took about a 12 provider group and flipped on Kevin, and they saw about a 256% increase in care gap closures just on preventative services, not ancillary services or other kind of clinical care rendered, but just the preventative side. They're doing about $4,500 to $5,500 per provider per month increase in reimbursement. Solo provider practice, and we flipped on Kevin, and they doubled their collections.
Greg, thanks so much for hopping on today's podcast, and excited to speak to you and talk shop about the work you're doing at Valor Solutions. You know, you yourself, like from what I understand, you've built a whole career in not just billing, consulting, practice operations. From what I understand, you used to even like manage billing for a 40 plus provider pediatric group at once in your career. What inspired you to focus on technology, and how did this idea for your digital medical assistant, Kevin, take shape?
Yeah, well, I originally got started in medical billing and had a medical billing company. I was providing those services. And so we were doing that and kind of growing in that space and solving a lot of those, the revenue cycle issues that we were having operationally, as well as supporting the clinics and improving kind of their operations. And we just started tinkering around because, you know, when you think about the, you know, EDI files that we get back and, you know, 830, you know, sevens coming in, it's kind of like a giant stack of paperwork where even if one person solves that problem, the rest of the people in the team, 10 or 15 people, don't necessarily know what that solution is. And so our job became, how can we as effectively as possible understand why claims aren't getting paid, what the solution is, and then immediately scale that and just say, hey, you know, every claim now gets this rule and this bit of logic to make sure it's, you know, appropriately and accurately passes, you know, claim edits. And so we started tinkering around with automations, and we started building our own automations for our own internal operations. And after doing that for like even less than 12 months of running the medical billing company, I was like, this is just fun. Like, this is the problem I want to solve. This is what we want to get into. Just started kind of pivoting and started looking to say, hey, how do we kind of get involved in this more and more? And over time, it just became really evidently clear I was running two businesses, a technology business and a medical billing business. So just said, hey, it's time to exit the one and just go 2 feet into the technology side, and kind of jumped in over there. So that was kind of a little bit about how it got started, how I kind of whet my appetite for technology, and then said, oh man, we got to go spend all our time doing this.
Yeah, sounds like the work you started doing with automations and with claims and claims denials and rev cycle really started to move you in one direction. You know, it sounds like.
Yeah. Well, and also too, you know, the claims adjudication process really starts at the front office, right? And so our ability to collect good information from patients, our ability to document well in the progress note, like all of these things are impacting whether or not a claim is going to get paid. And so we really started kind of thinking too about moving our kind of effort further up the process and not just focusing on the billing side. And we just started, you know, we started building custom automations and listening to clients and kind of saying, hey, what are the pain points? And just obviously our experience from, you know, industry knowledge and kind of being in the domain, we started getting very clear kind of signs of like, hey, these are the things that are making the biggest impact for clinics. And so, you know, that's really ultimately what started building out the core functionality of Kevin is kind of looking and saying, hey, we know that all these patients need a lot of care. We know that we can help, you know, medical practices increase their collections by, if we're doing like an absolute outstanding job, we can increase it by 4 to 8%. Like if we're just knocking it out of the park. Mm-hmm. But we know that these doctors are missing the care that they're supposed to be rendering to the patients, whether the insurance companies are asking them, whether it's, you know, kind of best practice from a clinical perspective, they're missing all these opportunities. So we said, okay, well, let's focus it on the front of the funnel and say, hey, if we can help support in closing these care gaps, why not spend our time trying to increase practice revenue by 40% instead of trying to increase collections by 6%?
Right. Because there's a lot of focus, I think, in the medical billing space with just like claims denials. It's like, what are your top reasons for claim denials? Like you can look at top 10, you can look at historical data. But what you're saying is like what happens at the front end with the, you know, provider and the patient is even like as important or more important, you know, can have a bigger impact on revenue and the practice.
Yeah, absolutely. I mean, at least from, you know, my research and kind of what I see empirically is if you have a patient who leaves the clinic, you have about a 12% chance of them re-entering the clinic for a non-acute issue, right? So just trying to get a patient to come back for that preventative, because we focus on that kind of primary care, geriatricians kind of areas, kind of our focus, the chances of getting that patient to come back is really difficult, right? So at point of care, if you can take care of more today, do that for them. And it's kind of a win
Yeah.
for the patient. They don't have to come back and kind of get more done.
Interesting. 12% seems so low, like a percent for them. Yeah. I mean, I'm thinking back to myself, like even with my, dentist going in for a procedure, like I know it's a different space than you guys, like not going back, a second time because it's preventative, right? And that's a lot of patients look at it that way, but the reality of the matter is healthcare is something that you need to be able to manage around the clock, and preventative, measures are only going to get more important as we can screen earlier for conditions. Diagnostic tools get better in the home, So with that in mind, like what you mentioned, like you're primarily working in like internal medicine and geriatrics. I think primary care is part of that too. What kind of like pain points are you seeing amongst these groups, especially with how they like manage multiple like value-based contracts, different programs, and contractual relationships with payers? Like, what are you seeing in your line of work with these groups at Valor?
Yeah, it's a bit of a conundrum that especially small independent practices are struggling with, in larger practices too. But if you just think about it, they're getting probably somewhere between 8 to 15% of their revenue from value-based contracting. They could have as many as 40 to 45 payers in their payer mix. And not all of them will have value-based contracts, but maybe 6 or 7 that they have to handle at one time. So you got this really big puzzle of which patients do I render care for at what point in time, while also recognizing that it's only 15% of your revenue, right? So it's really complicated because a lot of times there is overlap in value-based purchasing arrangements, but there's also really subtle changes that make you have to like, okay, which patient is this? Well, it's Blue Advantage. Oh no, it's no, it's WellCare. So how do we take care of this patient? Which is a little bit, frankly, a little bit silly to be trying to like striate populations based upon just their insurance. So that's a huge complaint. The other thing too is, because there is federal reporting requirements, there's a lot of work around like, MIPS reporting, and there's a lot of functionality that comes out of the EMR. But the problem is, so you now have like your Medicare reporting, which may or may not be helped out by your ACO. You might have other value-based contracts. And then there's like idiosyncrasies of the practice. Clinicians are like, hey, I do a lot of procedures. That's really important to me. I screen for diabetes really heavily. I do, I bring in somebody to do nerve conductive studies so I can check for peripheral neuropathy. So, you get these sort of, idiosyncrasies of the practice that you now are saying, well, how do I then standardize? I'm trying to standardize the care for these value-based purchasing arrangements. How do I also standardize this care across what the things are that are important to me? And people aren't really capturing that and thinking about that. And so now what clinicians are doing is they're going to 8 different portals and they're saying, okay, well, let me go these 5 patients need these things. Well, when are they coming in next? Oh, they're not scheduled for an appointment. Let me schedule them for an appointment. Or, oh, we just missed it. They came in yesterday. And now they're just like tracking everything down. It's just kind of a nightmare, kind of a pain in the butt. And that's kind of happening kind of everywhere. Yeah.
And is that how like Kevin comes into the picture? And if so, like, how does your medical assistant like Kevin work behind the scenes?
Yeah. So, it's really about data. And so our integrations pull a significant amount of data out of the electronic medical record. And what we're trying to do is provide a more comprehensive picture to where the patient's at in their care journey, right? So if a patient let's say, needs an annual wellness visit, which is really simple, the work that the clinic needs to do is first to understand, does this patient have an appointment? Yes or no. If they have an upcoming appointment, is the care gap even open? Yes or no, right? So is the care gap open? Are they scheduled for an appointment? And did the care gap get closed? So that's the first thing at a population level, is being able to say, hey, Kevin, how many of my diabetics have had an appointment in the past 90 days? Because in theory, if I'm providing quality care, my diabetic should be coming in every 90 days, right? Okay.
Right.
So then you take Kevin, he's giving you population level data, and you say, okay, point of care, Kevin, I got this patient coming in because I'm seeing 25 patients. I'm seeing 30 patients. I don't have time to check every single patient and chart prep every single one. My medical assistant, is running around crazy. I'd really love it if you just told me, like, what are all the things that the patient needs? Because the patient's going to tell me what their number one priority is. Like, if they're sick, they got a sore throat, they're going to let me know. Let me know everything else I'm supposed to do that I know I'm supposed to do. Tell me those things in advance. And based upon the data that we've aggregated and pulled in, if I told you and trained you, Kevin, on how to do this, I'd actually like you to do the work for me. Because ordering a mammogram on a female who's over the age of 45 is not, it's not clinical decision making. It's preventative medicine, right? It's a standard of care. It's a standing order, but managing that abnormal result is clinical decision making. So, hey, Kevin, why don't you, if that mammogram hasn't been ordered, why don't you order it for me and just like place it in the patient's chart, right? And so when we start doing that, all of a sudden the provider's care gap closures just start skyrocketing, right? Because if you think about it, like, what if your providers who are human went from closing care gaps 60% of the time, maybe 50% of the time, to just 100% of the time, based upon the conditions that they find appropriate for Kevin to do. So all of a sudden you start doing that, and it's just kind of like a light bulb. It's just like, there it goes.
Yeah.
Just
I mean,
everything
it
gets switched on.
literally goes back to what we were saying about, being proactive and, not being reactive in the system is so important. But how does like Kevin like get the data to make those decisions? Like, can you speak to like how this integrates into like clinical workflows for practices without adding like new tools for their staff to manage? Because I think there's always this concern in healthcare where my team like has put all this time and attention into like our EHR, EMR. It's like the last thing we need is another tool to like, use, right? That's gonna and someone made this analogy the other day, which I think was perfect, is like you don't pay them to like learn how to use the technology, or like do the technology beyond the EHR where they know they have to use it because that's how they submit, charges, right? And add their codes. Like, so anyways, how does like this integrate into their clinical workflows without adding, new tools for staff to manage?
I had a practice administrator tell me straight to my face, I need another portal like I need a hole in the head. Like, do not make me log in somewhere else and don't make me go anywhere else. Like, I am staying in my EMR. I was like, got it, perfect. And I think it's really true. I don't think more administrative work is solving problems in healthcare, right? So the first and foremost is the data collection that we do is EMR agnostic, and it's also, completely behind the scenes. So we basically get a login and password, and we're able to just, work, integrate with the electronic medical record. Some of our integrations with, we're integrated with like 3 major EMRs that cover like 60 to 70% of the outpatient, kind of world are fully automated. And then we built our ingestion and aggregation process to, again, be EMR agnostic. So if we literally just got like a spreadsheet, that's all we need, right? So in that way, we're able to integrate really quickly and really rapidly with new EMR. And then all of our integrations go back directly to the patient's progress note or back directly to documentation in the patient's chart. So what's really important is the setup, is understanding kind of like the standing orders, clinical indications, the when, right? When should we be chart prepping these things? What do you want to have chart prepped? Once we understand that, we can set all that up and Kevin can just run. And so he's able to do all this work. He's sending out grids on a daily basis to people's emails. He's chart prepping the documentation into their progress notes. He's texting the patients the forms that they need to get filled out in advance. And again, everything's driven back to the clinical note for the provider. So I think your sentiment is spot on. Everything has to stay back in the EMR. The portal's there. It's great analytics. We have great dashboards for people to like check in on information. What's their care gap closure rate? Who's close to the most care gaps? All that's there. But providers, don't like getting in there.
Yeah, so it gets a little competitive with who closes care gaps, like in a good way, a healthy level competition is what you're saying. Yeah,
I think providers are naturally competitive. I mean, I think maybe as doctors, it's tough to go through, and I don't know, I have no reference point, but residency and so many years of schooling and just not want to kind of be the best. And so I think the data is in a healthy way really helpful information. And so we give them kind of metrics on what care gaps are you closing, which ones are you missing, what's your comparison to your peers, and it's really great data.
Even within their same group or amongst like peers at similar types of practices too. Like, is there, because I think a lot of what happens in healthcare is so focused on your practicing group when it's like sometimes like the bigger picture helps with not like I'm saying like big picture like whole industry, but at least in your geography or your market, where you tend to serve similar patient populations, right?
Yeah, it's really focused on the clinic level, and we have the we have a SaaS model, but we also do extend also into some like consulting support too. And that's where that kind of like industry standard saying, hey, you're kind of all your providers are consistent with each other, but they're consistently at 40%, and that's not ideal. Hey, let's talk about that and see how we can improve it. So absolutely, we sort of lean in and kind of help additionally as is needed.
Yeah, spot on. And with this, whole like Kevin medical assistant, like for the non as technical folks in the audience, like what is the AI that like powers this medical assistant? Like, is it? It sounds like it has some generative components to it because or autonomous component. I think there's a term in the industry you might be familiar with, are called like agentic agents. Like basically agents that can perform actions based on data it's trained on.
Yep.
Like you were giving the example earlier, like it can even order a mammogram and place it in the patient's chart. So are there components of this solution that make it like generative or generate gen AI focused or autonomous? Is there any components of that?
Not really. And truthfully, it's a very important line that needs lots of discussion, and one that we're not in any way broaching, which is clinical decision making, as it relates to sort of AI, right? And
Yeah.
so where we get is we work to provide an environment that turns, to use AI to turn clinical speak into the stratification of a patient population. So somebody in our platform can really easily say, hey, I really want to see all my diabetic patients who haven't had monofilament testing, and I think they should get it done every year. Or they should have a microalbumin every year. Or maybe it's, I want to see all my patients who have ischemic vascular disease and haven't had an appointment in 6 months, right? So then what we need to do from that is take that information and then apply those as, structured filters against the patient population, because no practice administrator is going to figure out if a patient over the age of 50 and diagnosis list these 15 diagnoses, and right,
Right.
like if then logic against the patient population is really what we're providing them, an environment to do really seamlessly and really easily. Now, they also during setup get to say, hey, if my patient is due for this condition and has this condition, as a standard of care, I would do blank, right?
Yeah.
And so then we tie workflows to clinical conditions, and we say this is how we should treat this patient with this condition. And so really it's really using the technology to truly automate things that we know we should be doing. We just don't have enough time in the day to do. And so in that sense, it's really not it's not taking away that clinical decision making. It's not making decisions on behalf of a provider. It's saying, hey, tell me what you need to have happen. Let me be that digital medical assistant and really close care gaps at a rate you've never seen
Yeah.
before.
I like how
Um,
you describe that, like with kind of like if then logic for patient populations in a structured environment. Like if you gave the example, my patient is due for this condition, as a standard of care, we should do blank. Like, and it's pretty amazing. Like I mean, this is, not just with, your market of primary care, internal med, and like geriatrics, like this problem like escalates the larger industry at whole. Like we don't do a good job of like providers of suggesting care or pinpointing where the care gaps are for patients. It's all like reactive, like you said,
yep.
most patients just come in when there's an acute condition or a complaint, that presents. But it's like, as the system, we need to do a better job of like identifying that for them ahead of time and saying, hey, it's been you're 3 months overdue from your last checkup for this, for your diabetic condition or hey, it looks like this popped up. Like, it's, consider making an appointment here. Like how many patients would be benefited by that if we had a system in place that could do that, And it sounds like
Yeah.
Kevin is chipping away at this, And on that point of being like slow and steady, like what are some of the biggest like adoption hurdles that you guys have run into, and how are you helping like practices get comfortable with this, AI driven support, because that's different in its own.
Yeah, great question. It's really interesting. I think the advent of telehealth around COVID really made the conversation, and AI is ubiquitous, right? So everyone's talking about it. So
Yeah.
I think telehealth in COVID plus everyone talking about AI has made the conversation of like, hey, we'd like to talk about AI agents in your practice actually really easy. I mean, we got salespeople who are just calling people all day, every day. And that is never the hurdle, is like, are you comfortable with AI in your practice? They're like, yep, we know it's here. How's it going to help
Yeah.
us? The
Right.
biggest hurdle is usually around provider workflows and making sure we customized everything to meet the provider where they're at. So first off, the clinicians are always going to ask, why is there something in my progress note? Right. And so rolling this out and doing a training with the whole staff to get them on the same page with, hey, this is what's happening
Mm.
is pivotal. That always happens. We always have to do a training with the whole staff before we go live. The other thing too is really respecting, providers sign their own notes. So there were providers who are like, hey, I'm not comfortable with anybody touching my progress note. Sweet. Awesome. Kevin is totally capable of just sending you the information of who needs what, not touching anything in your progress note. We'll leave that up to you, and give you the data on your care gap closure rates against how everybody else is doing.
Right.
And if it makes sense for Kevin to help you in the future, he can. So customizing in that respect, and also making sure, like, one of the things, that we help with is like cardiovascular counseling or, obesity counseling, right? So if the provider's like, well, that's not how I would counsel, like, that's not the documentation I would do to counsel. It's like, great, let's make this your clinical note. Let's make this really specific to you. And so taking the time to sort of like customize the documentation, or like, hey, I don't order that hemoglobin A1C. I order this one because it's with whatever, for whatever reason. So making sure that we're ordering the right test for them based on how they practice medicine is the kind of biggest hurdle, but frankly also is the biggest key to success, because once it's dialed in and you're, really doing everything the way they want it, they're like, do not take this away from me. Like, this is awesome. This is exactly what I need. Yeah.
Yeah, no, that's spot on. I mean, it needs to be, I think that, regardless of the AI advent, that's always been the case with technology, is like the technology is only as good as the process and the person using it, So like if you don't have the right process, or it's not geared towards the person using it, it's not going to be adopted, long term. But the fact that you guys are able to customize both to the person, the provider providing the care, and their process of like you gave those examples with cardiovascular counseling or signing charts, like it's got to be customized to their process, the way they're not just used to seeing something, but the way they're used to providing care, right?
It's a legal document. It's got
Yeah.
their name said signed at the bottom by, like, for
Yeah.
sure.
Yeah.
Yeah.
And what type of impact are you seeing in the practices that Kevin is in so far, whether that's financial, clinical, and
Yeah.
how do you frame it up based on that impact for groups that are, still quote unquote just billing focused, that, yeah.
Yeah. I mean, we had one clinician who frankly was really struggling, financially. And it was kind of from the era of, because there's a day and time when providers would just like stick up a shingle and be like, hey, I'm here to see you. And the doors would be flooded. They'd be doing really well, and just saw patients and took care of patients, and they were doing great, right?
Yeah.
Those days are kind of gone, right? You have to be really, really scrupulous about what you're doing, how you're rendering care, how you're running your practice. And so he was really struggling, and solo provider practice, and we flipped on Kevin, and they doubled their collections. So they just like straight 2x'd. Now, granted, he had a lot of room and opportunity for improvement, but all the things that he was doing, but wasn't like just billing for, and was, preventative services that he was providing that insurance companies wanted him to do, he just wasn't getting any reimbursement for the work that he was already doing. So that was really huge, and frankly, just like kind of a feel good, right? I mean, not to get on a soapbox, but for me, I think the small independent practices, like, I'd rather go see a small independent practice. I'd rather not go to the massive hospital system.
Right.
So I think it's really cool to be able to see providers in that space, doing really well as a result. On average, I mean, we took about a 12 provider group, and flipped on Kevin, and they saw about a 256% increase in care gap closures. They're doing, maybe just on preventative services, not ancillary services or other kind of clinical care rendered, but just the preventative side. They're doing about $4,500 to $5,500 per provider per month, increase in reimbursement. So pretty conservatively, 15% increases in reimbursement cash collections by provider is really realistic.
Yeah. Those are two powerful examples with, from the solo provider to 10 plus providers, you said, right? So
Yeah.
it speaks to, and I'm sure they also appreciate your background coming from the world of billing. You've been able to build and design a technology that works with their existing billing workflows, other workflows as well, like we talked about. But I'm sure practices appreciate that from your background, and you've embedded that knowledge into your solution.
Yeah, 100%. Because when we're teeing up the provider's progress notes and we're giving them everything to basically say, hey, here's what you should be doing today. What would you like to have happen? They're like, oh, here's how I would document perfect. we also help them make sure that they're adding the appropriate and applicable ICD codes, appropriate and applicable CPT codes as well. So we're teeing up their chart, right? I mean, we can get like 60 to 70% of a provider's progress note done before they ever see the patient. So yeah, it has a huge, huge impact on them.
I'm going to make a bold claim and say that a lot of like even newer or old school providers or new ones coming onto the field still don't even know what CPT and ICD-10 codes are, like it's like, and I know like it's funny to us, but like, it's that, or they outsource it to another group and they never really touch it. So even if they ask the question, well, where am I going wrong with my practice? Or like, where are the opportunities to not just improve care, but improve financially? They can't get the answers they can't make sense of the answer, because it's not something they've managed, themselves. And so mind you, that's not representative of all physicians out there, but just bold claim that,
I think you're spot on. And I just don't think I don't think they're really set up for success to run their own practice because, I mean, they go to school for how many years to learn so many things, but how to run their practice or how to understand the billing side of the house is just not any part of any curriculum I've heard of, right? And so I think it really puts them at a disadvantage for sure.
Yeah, spot on. And so for those like clinical leaders out there that are listening and thinking, this is what we need, I'd like to try Kevin out. How do they connect with you and your team and learn more about the Valor Solution?
Yeah, I think an outreach and LinkedIn is always appreciated. Gregory Ally up on LinkedIn, and they can also anytime submit something to our website, thevalorsolution.com.
Yeah, spot on. All right. Well, Greg, it was a pleasure speaking to you today. I'm excited to keep tabs on your guys' journey. You're doing some really interesting work with Kevin, and I appreciate that you came from the world of billing, saw this opportunity and need, and really built a solution and technology around it that's now being used by practices of all sizes, in different specialty areas as well. I'm sure once we talk again in the future, I wouldn't be surprised if a year or two from now, you've expanded beyond, just internal medicine, geriatrics, primary care, into maybe even one day bigger health systems that need this, so.
Here's to hoping, man. Thanks for the time.